Okay, let's get started. I know more folks will be coming in, and this is recorded. Hello, everyone. Welcome to this special cross-pillar webinar hosted by Robert Wood Johnson Foundation's 4-Action programs. That's Systems for Action, Policies for Action, Evidence for Action, and Health Data for Action. These 4-Action programs are national research program offices of the Robert Wood Johnson Foundation. They share a shared mission of funding rigorous research that studies the impact of innovative programs and policies on overall health and well-being of communities across the United States. I'm Allie Bloomgarden. I am the Senior Manager of Advocacy Engagement at Partners in Health United States, and I have the honor of moderating today's webinar session titled Equity in Action, Navigating New Landscapes in Health Equity Research, which you probably know because it was on the last slide and you RSVP'd, but just wanted to say it again. Today, you will hear from these 4 incredible researchers on the screen that are each funded by the 4-Action programs. They're going to talk about how they're navigating the current landscape, the current political and social landscape in the United States, as they are working to advance equity-focused research with community members. As with so many professional communities right now, researchers are facing unprecedented challenges, declining trust in institutions, increased scrutiny and politicalization, and shifting funding priorities. And I know I'm grappling with this question, and we're all here today to grapple with the question of how do we adapt our work to ensure its integrity, its relevance, and its impact in this evolving environment that prioritizes justice and community. The 4 panelists here today, these 4-Action investigators, their research centers on some of the most critical and complex infrastructures that not only shape life in the United States, but are under attack. This includes immigration systems, the conditions and rights of frontline workers, access to and equity within public benefits like SNAP and Medicaid, and the broader systems that govern health and social equity in the United States. Each investigator here brings a distinct lens to their work that we're going to get to hear more in a second when I stop talking. Their lens explore and address the root causes of health disparities. They're identifying pathways to improve health and equity and community well-being. They're partnering with communities to co-create solutions. Their research is grounded in community, in action, in accountability, and reflects a shared commitment of all of us here to advance equity in ways that are responsive to the lived realities of community, particularly centering historically marginalized communities. I do have a few housekeeping items before we get started, and then you won't hear from me much longer. As I said at the top, today's session is going to be recorded, and that will be shared out with all of you who RSVP'd. The organizers will send a follow-up communication with the recording, as well as the slides and some of the links that the panelists share. We are going to have a section for Q&A. It'll be in about 45 minutes from now. It'll be about 15 minutes long, and then we'll wrap up by 15 minutes after the hour. If you have questions, please put them in the Q&A box. Hopefully you can see that on your end. And it's at the bottom of your Zoom screen, and you can answer your question. And then we'll hopefully get to those during the Q&A. Also, when you ask your question in the question box, please indicate if it's for all the panelists or which panelist of the 4 you would like to address this question. Also, the chat is active. Please feel free to use it, introduce yourself, say hey. We want it to feel like we're all in the room together in person, although this is virtual, but we can pretend. So, as I said, we are joined by 4 brilliant panelists today. When I moderate calls, I often like to name that no panelist is representative of the whole movement for health justice. They're here to share how they're navigating this moment in their work with their staff, with their communities, with their allies, with all of us here, and they're experts in that. I also just wanted to say thank you to all of you. There are over 300 of you here. I know that you are working hard and fighting to do work more likely than not with fewer resources than you had 8 months ago. And we don't take lightly that you're spending this time to join us today in this virtual space. Okay, enough for me. I am going to hand it over to the panelists now to introduce themselves and their project with for action, and then I'll guide us through a conversation with some prepared questions. So first, well, let me just introduce all four of them, and then I'll ask the first question. So Professor Chima Ndumele is the professor and chair of the Department of Health Policy and Management and co-director of Scale Initiative at Yale School of Public Health and is representing Evidence for Action today. Dr. Ian Stockwell from Health Data for Action and also the Associate Professor of Information Systems at the University of Maryland, Baltimore County. Dr. Jessica Santos with Policies for Action and the director of the Leah Zalman Center for Immigrant Health Research, and Dr. Caroline Fichtenberg with Systems for Action and co-director of the Social Interventions Research and Evaluation Network, otherwise known as SIREN, at University of California, San Francisco. So, Professor Ndumele, I'm going to ask you the first question, and then I'll pop it over to the rest of you. If you could take a few minutes to tell us about your research project with For Action and how your research has been impacted by recent challenges in this political context.
Sure. Thank you, Ali, for the kind introduction. And I'd also like to thank the Evidence for Action and the broader For Action community for providing funding for our work here. So I'll take just the next few minutes to talk to you about our project and what I think the implications are for the current moment. So our work broadly was designed to understand the interaction between social policy programs in the U.S., in this particular case, the Medicaid and SNAP program. As we all know, policy is often made in silos that doesn't quite reflect the way that people live in their actual lives. Therefore, despite the fact that multiple people are both in the SNAP and Medicaid program, SNAP policy often doesn't account for Medicaid in the way that they make policies, and Medicaid often doesn't account for the SNAP program in the way that they make policies. So we leveraged the reintroduction of work requirements in SNAP. So we went back to 2016, 2017 or so, which is the last time that the SNAP work requirement program had been paused, or one of the last times that it had been paused, and we watched the reintroduction of those policies to understand what it would mean for the way that people interact with the system for those who were jointly enrolled on both SNAP and Medicaid. So just by way of background and to orient folks to the experiment here, in Connecticut, which was the primary place for our experiment, about half of the people lived in towns that were exposed to SNAP requirements, and the other half of individuals lived in towns that were exempted from SNAP requirements. Therefore, we were able to kind of compare outcomes for the people that were exposed relative to the people who weren't exposed. We found several things happened for people who were exposed to SNAP work requirements. One, about 25% of the targeted population, typically referred to as ABODs or able-bodied adults without disabilities, were almost immediately dropped from the program for not being able to comply with SNAP work requirements. And the effect was, as I mentioned, both immediate and sustained. So it lasted for about 18 months. We estimate that people that were subject to work requirements lost about 18 months and about $3,000 per individual in benefits over that time period. The impact of this was not felt equally. Older beneficiaries, individuals with chronic conditions, and individuals who received more in benefits from the state were more likely to be the ones that lost coverage. So in some ways, it undermines one of the fundamental rules of the safety net, which is to care for the neediest. Um, we were able to leverage a second experiment in which about a year after the initial introduction of SNAP work requirements, they were then eliminated in some towns. Unfortunately, we found that even in towns where the SNAP work requirements were reversed and people were then eligible, less than 25% of people who left the program initially came back, suggesting that it is often easier to kind of implement these policies and to make people lose coverage at the with the keystroke than it is to have people engage with the administrative burden and all of the challenges with reapplying and recertifying for the program. In our ongoing and nearly published work, we also find that SNAP work requirements have deleterious impacts on Medicaid spending. That is particularly for people with chronic conditions, losing your SNAP, like diabetes, losing your SNAP coverage increases Medicaid spending, particularly through the mechanism of increased hospital use, especially for those with chronic conditions. So what does that mean for this current moment? Obviously, in some ways, our worst fears have come true. The program, the work requirements which were then somewhat limited to the SNAP program, have now been extended in SNAP and expanded to the Medicaid program. It is helpful that we have some information to be able to forecast what states are likely to contend with, and some thoughts and solutions about ways in which they might mitigate some of the worst circumstances. But quite frankly, we move forward with quite a bit of humility, understanding that this is really an unprecedented circumstance in which we are going to have to figure things out to step by step on the fly, and in which many people might get hurt as a function of this, both in the SNAP and Medicaid program. That's before you even think about the interaction between the two programs. So we are happy to be able to assist, but daunted by the work that our nation kind of faces ahead. So I'll stop there and turn it over to the next panelist. Thank you.
Thank you so much for sharing that. I already have 1,000 questions for you, in addition to the ones already prepared. But we'd love to also hear from Dr. Stockwell for you to answer the same question of tell us about your research projects with For Action and how your research has been impacted by recent challenges in this political context.
Yeah, sure. Thank you so much for the question. Thank you for having me. I'm also interested in Medicaid and specifically my Health Data for Action project, along with Dr. Sally Chan, who's on the call too, is about examining the longitudinal experience of young adults with special healthcare needs as they age out of Medicaid, with kind of a sub question being, and how does Medicaid expansion affect this trajectory? Right? Like the prior panelists, we had kind of a natural experiment set up in the state of Virginia, where we were able to acquire data from both the Medicaid plan and private insurers with an individual identifier that spans all payers. Both prior to and during their Medicaid expansion, right? So we have this wonderful data set where we can say, okay, what was happening to young adults with special healthcare needs as they aged out of Medicaid prior to Medicaid expansion, and then what has happened since. I wish I could tell you the answer. We're halfway through our data analysis and have numbers coming out of our ears. So we don't know yet, but we really need to figure out the answer. And this gets to the impact question of the current environment. We really need to get to the answer because we don't know what is going to happen to Medicaid over the next 3.5 years. We don't know what's going to happen to Medicaid expansion. I'm generally, I'll admit to however many hundreds of people are listening, I am generally not a positive person. However, the way that I'm trying to think about this is that as managed care continues to increase penetration in Medicaid, there is a business reason that the answering these questions are important, right? We know that continuity of care is extremely important to the individual, our study population. We know that continuity of care can impact costs and utilization for these folks. And we know that cost and utilization are the framework around which managed care operates, right? So um, I'm not seeing it as a positive that we're in our current situation, more of a let's make sure that our findings can be relevant to the stakeholders who may be able to use them um, most given the current environment. That's it. Thank you.
Thank you. Those are important questions to note about how we can make light of the situation and what we can do that's most strategic, and we'll get into that a little more. But I will now invite Dr. Santos to also answer the question about your research project with health, with For Action, and how it's been impacted over the past few months.
Yeah, great. Good morning, good afternoon, everyone. Thanks for having us. We are running a participatory action research project out of the Leah Zalman Center for Immigrant Health Research. And I'm going to name our partners right off the bat because it is a participatory project. Together with Dr. Ariella Braverman-Bronstein, she and I are co-leading the team at the Institute for Community Health, where our center is located. So we have a team of researchers that are trained full-time researchers at the center. And then we have a partnership with the Massachusetts Immigrant and Refugee Advocacy Coalition, or MIRA, one of a very well-known national advocacy organization that is based in Massachusetts. And then we have a team of co-researchers that we hired just recently this summer to join, who we're training up and working together with for field work that we'll be starting this fall. The goal of our study is to, it's called Policy on the Front Lines, Narrative Change for Immigrant Well-Being. And we're really interested in, I agree with what Chima already said about the fact that policy is made in a vacuum. We want to know what policy looks like when it when the rubber meets the road, like on the front lines. What does it look like in healthcare right now for folks working in healthcare, in primary care with immigrants, both as patients, coworkers, leadership and doctor positions, and trying to figure out how to parse through all of the immigration policies and health policy changes that are rolling down and hitting the front lines. So our study itself is going to be looking at the current narratives in healthcare and then developing and testing counter narratives to advance immigrant health and well-being. Originally, we had proposed to study a specific policy area, and we spent the first couple of months of this study hosting, participatory decision-making sessions about what policy to focus on for Massachusetts specifically. It was right at the end of the fall last year, coming into the winter, and we couldn't collectively identify a policy that made sense because we knew it could change overnight. And so that was one of the biggest impacts right away that this, political climate had on our project. So we shifted to focus instead on a sector, and we focused on healthcare because we think that there can be a lot of really incredible mobilization that can happen through our narrative research. Once we have some findings to disseminate, then it will actually become relevant to a wide range of policies. But rather than starting with a sort of specific policy area and accompanying advocates through the research, we're going to be doing it from a sector perspective. A couple other changes. Participatory action research is can be slow, but can be incredibly deep and produce quality results. I think the political environment has made our study both maybe slower and more important to everybody who's a part of it. The narratives right now at the environmental, cultural level in this country about immigrants are specifically harming health already, harming the health of immigrants and all community members who are trying to figure out how to, navigate this current system. And so we know that at the cultural level, that's a really big, attempting to change the narratives at the cultural level is a really big task. So we are focusing much more specifically at institutional and interpersonal levels for this project, and looking at working directly with hospitals and healthcare folks. We're going to be entering the field in the fall. So I think that our study is somewhat on track from a timeline perspective, but it does feel like it takes a lot more emotional energy and time. And we are having very intentional conversations among our diverse team about who steps forward, who and in what situation, who steps back, protecting safety and well-being for our entire team. And then I think the last of impact I'll mention just off the top is the entire goal of our study is to have research that produces tools for advocates and not just findings that can go into a peer-reviewed report. And we may talk about this more later, but I'm struggling even at this early stage in the research to figure out how we're going to be talking about what we learn in ways that honor the participatory nature of the work while also protecting and, collaboratively figuring out what to actually release to the public or not.
Thank you for bringing up so much of the impact and also just naming for everyone here, whether you're a panelist or just a human being here, like this is all very personal. The work is personal for all of us in different ways and is particularly heavy for so many right now. And that's a whole other element of this that we will talk about in a little. But Dr. Fichtenberg, I would love to hear lastly from you, answering the same question. Please tell us a little bit about your research with 4Action and how it's been impacted by recent changes in the political climate.
Thank you so much. And thank you for RWJ for inviting me to present here. It's really a pleasure and an honor. So I'm based in California, and I'm part of a research center called Siren, where we focus specifically on evaluating interventions that seek to improve health and reduce health inequities by addressing adverse social conditions or social risk factors, things like food insecurity, housing instability, et cetera. And our Systems for Action project was focused on understanding really an innovative initiative as part of Medicaid in California called CalAIM, or one component of CalAIM. So CalAIM stands for California Advancing and Innovating Medi-Cal, which is the name for California's Medicaid program. And it was a whole set of different reforms of Medicaid in California, including a program called Community Supports that provides non-medical services for Medicaid members meeting certain eligibility requirements. And these medical services included services to help individuals who were experiencing homelessness, such as housing transition navigation services, housing deposits for when people need the first month's rent for an apartment, housing tenancy and sustaining services to help people stay in housed, and other services related to homelessness, as well as other services for other populations as well. And we were really interested in figuring out how is this being experienced by homeless serving organizations who are, for the first time, being given an opportunity, if they want it, to become part of the Medicaid ecosystem and to get paid by Medicaid to provide their services to clients. The part of the project I'm going to talk about right now is we did a set of qualitative interviews talking to a number of homeless serving organizations in 3 counties in California that have high rates of homelessness, and to find out what their experiences are like, what their barriers are, what the facilitators are, and also to understand, and this was a key part of our research project, how is this integration of homeless services into Medicaid in California advancing health equity? How are those implementing this program ensuring that they're maximizing potential health equity impacts? In terms of, and we're still sifting through the results, but I can give you some kind of preliminary things that are coming out of these interviews. One, that these homeless serving organizations have faced a lot of challenges becoming integrated into the Medicaid system. Billing Medicaid is really complicated. And it requires a whole new set of ways of tracking work for homeless service organizations that previously generally have been funded through grants, and now they have to track the exact amount of time they're spending with each client, et cetera. So it requires really changing workflows, new technologies, new expertise to figure out billing. It's often a lot of back and forth to get claims accepted. So it's been a real challenge for all of these organizations. Despite this, and this was really interesting to us, the organizations were really optimistic about this program and felt like after about 2 years, most of them had kind of figured out a lot of the kinks and were really committed to this program because it presented a whole new way of funding their services in a way that would be more sustainable. In other words, they wouldn't have to necessarily be looking for grants every single year. Instead, they could just have services that they provide to Medicaid members who are eligible through this community supports program and bill Medicaid. So that's what kind of motivated these organizations to overcome the challenges of becoming Medicaid providers. We found that a number of things that the state did was very helpful for these organizations. The biggest thing was providing startup grants, relatively large grants to organizations that were interested in becoming part of the system to buy software or to any equipment, to hire staff, to gain expertise, all sorts of ways for them to learn how to do this. And that was the most helpful thing that enabled these organizations to do this. And they wouldn't have been able to do it if they hadn't had that startup funding. The other thing that we looked into, as I mentioned, is this question of how are these organizations thinking about how this program advances health equity, particularly racial health equity. And there, we were somewhat surprised by the responses that we got, because we thought, given the health equity and reducing health disparities is one of the goals of CalAIM, we thought that there would be a lot more very explicit focus on equity as part of the implementation. And instead, we found that people felt that just by doing the program, that was helping to advance health equity, which is true. But they weren't necessarily thinking beyond that to kind of how do we make sure that we're reducing barriers as much as possible for the populations that might have the hardest barriers to accessing these services. Now, they do have language. Most of them have bilingual staff and ensure that they have language and cultural competence that matches their clients. So that is something that they are doing. But we were a little bit surprised that there wasn't a more explicit focus on equity as part of their work. And we attribute that to probably just the doing the work is all encompassing. And again, these are individuals who work in organizations that are already serving many of the most vulnerable in our community and people who are disproportionately people of color due to structural racism. And so I think a lot of them felt that the work that they were doing was already in and of itself advancing equity. So how our work has been affected, and I realize I might be going on a little too long, but thankfully, so far, even though the CMS has pulled back its guidance and its explicit encouragement to Medicaid programs to do these kind of social determinants of health focused initiatives, California is still going strong, still going in that direction. And a number of other states, we haven't seen yet any other states retreat from that work that they've been doing. So we think that our results are going to be really helpful for other states that are implementing these kinds of initiatives. That being said, the funding landscape, as we know, for health equity research is under attack. And we are all kind of waiting to see, what happens, particularly with NIH funding. And I think, anyway, we'll get into this more, but I think there's a lot that we can do as researchers to help make the case for why health equity funding is crucial for everybody.
Thank you. Thank you all for outlining the amazing work that you're doing. As I said, I have so many questions for you, but I'll stick to those that we came up with. And Dr. Ndumele, I wanna ask you, particularly noting your work with SNAP and Medicaid and the attacks and gutting of Medicaid just this summer alone, and the vulnerability of those who receive those programs and what it means for communities and the amazing work you're doing. I'm curious, like in light of this political polarization, how do we mitigate the risks and harms of the findings that you're coming across being misinterpreted or discredited or even weaponized against the same communities that we're trying to protect? Do we have to change how we're publishing or communicating or sharing data to actually get at what we want?
Yeah, it's a really good question. Thank you, Ali. It's worth noting that there are limitations on what we can do to fight misinformation, right? Anytime we are putting information out to the public, in some ways it becomes the public's within the public's purview to do within what they want. But I do think that there are things that we can do to mitigate the likelihood that these things are misrepresented or used in nefarious ways. And the first is to tell complete stories. Right. It is often the case that I think the news has a bent towards sensationalism, and we as researchers often want to publish the big thing, but it's important to tell kind of nuanced and complete stories. I suspect, my sense is that there's also a bit of a narrative that somehow the public can't handle complexity. But it's important to tell when things are working and when things aren't working. And it's important to talk with nuance and with detail in ways that are that really do adhere to the truth. I will say beyond that, though, it's truly important that in this moment we do a better job of moving beyond our traditional measures of translation. Our obligation in this moment is to carry our messages as close to the kind of to our intended targets as possible. And that means that it's probably not good enough to publish a paper and hope that somebody picks it up. Right. It may include writing a blog. It may include whatever is necessary to really get this full message to people in as unvarnished a pathway as possible. I think those are skills that we are going to have to learn and sustain in this moment.
I'm curious on a follow-up on that.
Sure.
If you need to communicate in different channels, who else do you need on your team that can help do that better? Like, do you need the 19-year-old who can translate it on TikTok? What do you need?
I think that's exactly right. I think particularly as academics, we are trained to produce the research. We're not trained particularly well to communicate the research. And we are going to have to extend and expand our teams in ways that require by the way, that we're not just telling the community things that they already know, that we're not just preaching to the choir. So yes, that might include the 19-year-old who knows far more about TikTok than I do. It might
Shout out to those people.
Shout out to those people. And it includes folks who think carefully about narratives. Right. This is as much as this is evidence about evidence. This is also about kind of instigating action here and getting folks mobilized. So we have to think differently than we previously have about how we communicate effectively.
I really appreciate that. And it also puts the onus on us to get comfortable being uncomfortable, to try things differently. We're all trained in our respected fields that we've been taught, like, this is the way you have to do it, academics and publishing, and that just might not work. I was just reading on some social media about a comms director who was saying, you know, my research colleagues are telling me that I'm not doing my comms work right. And they were like, but I was hired to do the comms. Let me do that. And how do we lean on each other's expertise and not make it harder when we have so many more barriers right now? Dr. Santos, I know you do some narrative work. You were talking about it, so I'd love to hear from you. Also answering this question of, in light of the political polarization, how do we mitigate the risks of these findings being weaponized, misinterpreted, discredited?
Yes, thank you. I have so much to say on this.
Go.
I'll start I want to just lift up the fact that I don't think the model was working before. So I'm glad we're changing it now, but we should have already been working to change it before. So all of you who are on this today, if you haven't already been thinking outside the box around like how to get your research findings out beyond peer-reviewed journal articles, I really encourage you this is the moment. And so, you know, the system is not set up to really change policies and to create social change through academic research. We have to create a system that will do that. And I think this is an opportunity to really test out and be creative and do things differently. So, you know, in partnering with Mira, we have the opportunity to not be the ones necessarily, once we have our findings ready, at the front lines speaking them out. And we did that intentionally from the beginning, knowing that it matters who's speaking as well as what's being said. And so, you know, we also, during our startup period of this grant, while we were figuring out where to focus and you know, putting the partnerships together, we contracted with Wonder Strategies for Good, a national narrative expert organization who I've learned so much from. And we asked them to do a national landscape analysis on immigrants in healthcare, just so we could have the sort of a larger evidence of framing to inform our Massachusetts-based work and our focus groups. And what they found was basically evidence of polarization, which, you know, would not surprise any of us. On the one hand, people are looking at immigrants as, you know, part of the larger community. So the pro-immigrant kind of way of thinking in healthcare is, you know, you treat who walks in the door. You treat anyone regardless of their background. So there's a lot of opportunity in healthcare to find kind of like values and, you know, kind of shared ideas and mindsets that we could mobilize for positive narrative. On the other hand, findings on the other side showed that, you know, the narrative that immigrants are a drain on the healthcare system is very prevalent, and that people might be getting cheated, you know, that people are cheating on taxes or something like that. And so it's like a direct fear against people's pocketbooks. And it gets at that, like the fact that we have a very, you know, unsustainable cost of living in this country right now. And so if they can trigger that fear that they themselves are losing out because of immigrants being in the country, then that kind of, you know, again, that mindset is deeper than just the message itself. So long story short, I want to say that our job right now is to figure out what is in between those polarized narratives. I believe that there is a lot more nuance than what we are seeing at the national level into how people really think. I know that a lot of conservative folks are not comfortable with ICE sweeping their neighbors off the street, right? We also know that people are concerned about safety and the economy and other things like that. And so I think our research has to have the larger context we have to keep that you know, sort of context in mind as we go forward and not contribute to polarization. So there are some ways that our studies on equity can potentially have some backlash effects or create harm. And so I think we have to be incredibly sensitive to that right now and just combat polarization and othering as much as possible. So one way we're doing that in our study is we're going to be focusing as much as possible on the impacts of policy on entire communities, not just on immigrant families or immigrant communities. It's actually on elders in the United States, for example. The entire like if we lose 25% of the healthcare workforce to deportation and detention, the elders all elders will suffer. So that type of thing, that's what we're working towards. And the last thing I'll say is that there's a lot of really incredible historically subjugated knowledge in communities of color, in immigrant communities, in Native communities that we need to be lifting up right now as part of the dissemination efforts that we're doing.
Mm.
Yeah.
Thank you so much for lifting that up. And Dr. Fichtenberg, I see you want to say something, please.
Yeah, I was going to say, I feel like I can jump in here if that's okay. Just to add that I feel very much the same way, that it feels like at this point in time, health equity has been, branded as a legal thing by the administration, the current presidential administration, which is, and we have to fight back against that actively. And in our communication, I think we have to preempt the distortions that are potentially going to happen. We have to expect them and preempt them. And I think one key way of doing that is in terms of highlighting the way in which health equity work is work that benefits everybody. So as Jessica just said, this is about the entire community. And I think, even though I think a lot of us on the progressive side feel like it's incredibly important to highlight who has been harmed the most and who needs therefore to be helped the most so that there can be a level playing field, I think we have to focus on the benefits to everybody in this moment. And like in every, op-ed, you're told to always say like your point, and then just to kind of preempt what other people's argument might be. And I think that that's what we need to be. And I think the language that I'm thinking about using, although I'm excited to see what RWJ's health equity effort, narrative change and communication health equity effort comes up with, but I'm thinking it's something about everybody having an opportunity to thrive, leveling the playing field, helping those who have been left behind, because I think there's a lot of folks on the right that feel that they have been left behind too in communities that have more rural communities that have been economically harmed by globalization and deindustrialization. So I think we need to really enforce that health is not a zero-sum game. Just like curb cuts help everybody, moms with strollers. I mean, I don't know if you ever notice it, but anybody who is walking at a corner,
yep,
even people who have very few mobility and no mobility limitations or different mobility needs will preemptively go for the curb cut. It just feels more comfortable. It helps everybody. And health equity efforts are the same.
I was going to use a very similar example. I'm curious, Dr. Stockwell, how do we protect the communities that we're partnering with from political or social retaliation? I know some folks are saying like change language that we use, and that could be beneficial. That could replicate the harm done. Is there additional consent or privacy or partnership protocols needed, particularly now more than ever, but also in general?
Yeah, it's a good question, and I think it relates to what we were just talking about, right? I mean, it's our job is to create knowledge and to find the best users of that knowledge, and I think, the way that we can best protect the communities that we serve is by using that knowledge the best we can. I mean, for me, and I mentioned this a little bit, finding overlap with protecting vulnerable communities and incentives, and sometimes it's financial incentives that align with that with actions that can protect them is really important. I think this matches with what Carolyn just said. If we can show that health equity, regardless of the language we use, right? Even if we don't say equity, if we can align a change, right, in action, this is for action, right? That's why we're here to act.
Nice.
We can align an action with a change that will increase the outcomes for the communities that we care about. I personally don't care what word we use for that. And I'll also say, and as I have some business background in entrepreneurship, um, it's really important to tailor that message to the people that we're trying to affect, right? The people for whom we want to act. Um, you know, it means not just changing the way we present our knowledge. It doesn't mean just changing the way that, or I guess, the avenues that we use to disseminate that knowledge. Sometimes it means changing the way we say it, right? To me, as long as we affect that outcome, as long as we can cause someone to take an action that makes outcomes better, um, that's what's important. And again, to me, I think that's how we protect these communities, right? It's about the outcomes, and we need to do whatever we can to get those outcomes to happen. I'll tell just a really brief story. As a data person, I'm one of the few that has had the chance to interact a lot with my stakeholder groups. And I remember distinctly as we prepared for this webinar, thinking about the meetings I've had with them where I looked around the room and I thought about how much it took for the people that I was talking with to even get to that room, right? People with physical disabilities, people that had to walk, 5 miles and 100 degrees to get to that room. And I think for me, and I think maybe for all of us, we need to do whatever it takes to help them. Like they were there for me, right? Like they walked those 5 miles and 100 degrees. If I need to not use the word equity to still get them the outcomes that I want, then I'll do that.
Can I underscore a point that Ian made? Because I think he made so many that were really valuable here. Uh, there is both short-term kind of challenges to navigate, and it requires that we also keep our eye on the ball in the long term, right? Uh, Presenting the evidence that policymakers and other stakeholders need in order to understand how valuable this work is critical. But we also can't ignore the fact that folks are under threat in the short term. And I think there are things that we can do there. I mean, first, we have to, inform people of the threat, right? Like we have to have room for all types of organizations. There are organizations that are going to want to be on the front lines, and then there are organizations that are going to want to do kind of good work quietly. And that's okay, right? That's how teams work. We can have room for different types of folks. I think the other thing that Ian said that was really, really important is that we have to have a commitment to partnership. And that's not just in the good times, but that's also standing with the communities that we serve in the challenging times. And I think that does a number of things. One, the more that we stand together, as opposed to having to stand individually, the more robust our efforts can be. The harder it is to kind of single out and target individuals. I think we need to stand up with and for individuals, even when we're not the ones being targeted, right? So the question is, how can we it's a broader question of also, in this particular case, what academia, particularly folks in public health, are required to do, and what their communities deserve. But I think the more that we stand up collectively, the harder it is to kind of target and single individuals up.
Dr. Santos, I saw you lean in. Were you trying to say something? Okay, you were just engaged. I want to move on to chat questions in a few minutes, but I'm on that note of we need to stand up together and we need to work together and not let our own communities and work be pinned against each other. What platforms or alliances really should we be focusing on or amplifying to ensure that we're following community voice both safely and strategically? Dr. Fichtenberg, I'm happy to start to you.
Sure. I think the key here is really taking the lead from the communities, the are the most vulnerable. I think Jessica highlighted this really well in her work. The need to really see it from the perspective. I'm not part of that group directly, and I need to find out what's going to feel helpful, what's going to be supportive, and what's going to feel risky to communities most directly affected. And I think follow that. So I mean, I think it's the principles of effective partnership, but to a new level because of the risk to certain communities, particularly immigrant communities right now, having been so amplified. So that's kind of what I'd say. I can't think of any specific platform or alliances except, partnering with continuing to partner with communities and following their lead.
I can jump in after that. I think even more, yes, and even more in the direction of equalizing power. I think we need to really examine our positionalities as researchers and all of the various identities that we hold, and the identities and positionalities of our partners, right? And so I think that is research work it's part of participatory action research, it's part of the method. But if we could incorporate it more and more into just all studies, I think that, it's not up to me. I don't even, the fact that I'm a PI just means that I've been trained in the academy to be able to have the credentials to get the grant. And I really do have some methodological expertise to offer, but I really see myself as leading a team. And so I don't see our study as having like a differential. I mean, there are real power differentials as well that we need to acknowledge and be aware of, but there isn't the kind of separation of researcher and researched in this work right now for us. We are in this together. We are examining this issue together, and we are working towards action together. So how can we like make decisions together, basically? So Carol, to your point, Carol, it is, yeah, just ask, like, and it's complicated. Nobody has the right answer right now. And so what's most important is that everybody on the team feels like, you've gone through an intentional process that's inclusive and arrives at a decision that works for everyone. And that takes time, but it's worthwhile because it's also better for everyone's well-being. It's better for the study as a whole. And so I think that might be, we just have to build those processes into our grants, like literally build in time for partnership work. And, I think we had a 3 to 6 month planning period built in, which is what we've been working on up until now, until we hit the field. And that work is, now we're set up to be able to just send some texts and make some phone calls or call a quick meeting if we have some decisions to make in the moment.
I think you bring up a really good point about building time for partnership and also building time for trust building with community. That doesn't happen overnight, validly so. And that doesn't, and it needs to be prioritized because otherwise it just means creating more research that sits in a vacuum and doesn't build on trust. And so I actually was going to ask a question about this, but someone in the chat said something similarly about strategies that would help sustain long-term community partners, particularly in ways that build trust and shared purpose, particularly in a time of growing fear and mistrust. And that goes to a question in the chat of how can community health worker roles be leveraged in any research to work together, because community health workers, I'm going to put the definition of community health workers in the chat for everyone, because I think this is really important, of who are frontline public health workers who are trusted messengers. And I think that's so much about trust. So I wanted to hear from any of the panelists about, have you thought about engaging community health workers? If so, how, or other trusted community members?
It's such a great question. I can jump in. I would say one of the challenges of our work, of my work, is that it tends to be at a bigger scale than like one community. So we're working, on something that's happening across the state of California. In another project, we're working in a project that works across the state of Oregon. So but we address this by seeking out individuals who are people with what we call, with lived experience, just the same way as have like, academic credentials. They have credentials from the lives that they've lived. And I think CHWs is a great idea. We haven't yet focused specifically on that role, but I think that you're absolutely right that they're a really incredible resource. But we do make sure that we have partners that are individuals. So in this case, for our Systems for Action work, we put together a racial and equity advisory committee of individuals who are thinking about this from a racial equity perspective because of their personal lived experiences. And that's kind of one of the things that we've done. Curious to hear what others think about this idea.
Yeah, that's fascinating. I can jump in. So not for Health Data for Action, but for some of my NIH-funded work, I'm partnering with a Medicaid health plan to identify from healthcare claims data individuals who likely have an unmet social need that is driving unnecessary healthcare utilization. That Medicaid plan employs a number of community health workers. And they employ those health workers to reach out to specific communities who match the backgrounds of the community health workers, to try and engage individuals in those communities in preventative care, help them enroll in things like SNAP, other benefits, and so on. And this kind of comes back to how I think about framing equity today, right? The plan is doing that and has seen value in that, not just because it's the right thing to do, but because they see a return on that investment, right? Community health workers they work to make the health outcomes of individuals in those communities better. And health plans, if you present it to them correctly, they can see the business case for that, right? So I'm sure it's not in all cases, but at least for some cases, you can align incentives such that, back to the language thing, right? We don't have to talk about equity explicitly. We can find systems that work to increase health equity for communities while leveraging kind of the incentive systems that are already in place. So I don't know. It's worked so far.
Thank you. Professor Ndumele, please. I saw you keep coming up.
Yeah, I will say, particularly as we work with states to try to mitigate the kind of upcoming crisis as it relates to figuring out how folks understand what's coming, what's required of them, how to sign up and navigate these systems. Every state that is trying to do this effectively should be using community health workers to do so. The reality is that there is so much mistrust of both research, technology, and the like, that there is nothing more effective than folks who really understand the experience of folks on the ground helping navigate the system, right? That lived experience, that shared experience, I think is going to be critical for how we navigate these times.
Thank you. Thank you all for sharing that. And I want to uplift something that was said in the chat that I think it's really important. When we're talking about bringing in community, they say, I think it's vital to ensure you're finding shared goals with your community members and not just seeking out members who are going to act as a liaison for your research goals. Also fairly compensating people for their time and not asking people to volunteer, which is often just not possible for lower income folks. So I want to name that, and I'm hearing that from the panelists, but I think it's important to say that. For any of the panelists who want to answer this, I see another question in the chat. For insurers who are no longer using health equity in their terminology due to fear of showing up on a DEI list, how do we think about tackling these issues without using this language? I know Dr. Stockwell, you've been talking about this a little, but I want to hear from the rest of you about the pros and cons of policing our own language out of the fear of community being policed.
I mean, I can say I think it's a really delicate balance. I feel like I'll be a broken record and just say it's a group decision and that you need to figure it out together, right? And assess the trade-offs. I think, for example, in Boston, we have a very vocal and strong um, mayor who is standing up clearly for immigrants right now in the state of Massachusetts, nationally being recognized for that, but also, being targeted in some ways for that and drawing attention to Massachusetts. I've talked to so many people about this, and I think there's I'm on the fence, but I think if you have the ability, the platform, and the privilege and the resources to stand up and use your voice right now, you personally are, if you can take that risk, do it. If you are putting others at risk as a result of you standing up, that's a totally different situation. I really admire the people who are standing up in municipal governments, in institutions right now, and if nobody is, then we are just going with the status quo. At the same time, I do think people are intentionally really weighing that balance and asking for input. And so when you see a politician stand up like that, they've gone through a very, very intensive vetting process to make the decision to do that. It's not just off the cuff. So I would just say, as long as you go through that intentional process and sort of decide where are we at right now in this group and in this project and in this context, how vocal can we be? I'm proud to say that at our center, we decided that we want to, continue using the language that we've been using at this time. At the same time, I'm not putting any language into federal grants. Um, and so, but when we speak publicly, we're being clear about how we feel about health and equity.
Thank you. I just want to note some points from the chat that in addition to thinking about trusted community members to partner with and work side by side with, thinking about community health workers, but also spiritual leaders and religious organizations, people who are embedded in community. I've seen that both in the question and in the chat, so I just want to affirm that. For the panelists, but I can also answer this myself, in terms of hearing that colleagues who are advocating in Congress against cuts to Medicaid and gutting of systems. Someone said, my colleague was told that data doesn't matter right now on the Hill and in certain states. I can speak from my own perspective as someone who meets with staff on the Hill consistently and in states that it's a mix of data and story, because if it's two numbers, it lacks the humanness. And if it's only a story, it's hard that about an individual, it's hard to think about, well, are enough people experiencing that for me to care? And so I encourage everyone here, whoever you are, your right is as a constituent to make your voice heard. I'm not saying lobbying or all of those things with your organization, but as an individual constituent to communicate what you're seeing in your community is so important, as are these amazing researchers who are communicating what they're seeing. But you don't have to just be a researcher to communicate what you're seeing. But I'm curious from the panelists, is there anything else you would say for how people can take language and data and use it to inform policy change and influence policymakers?
I mean, sorry, go ahead.
Just quickly, I think it is correct to say that narratives really matter to folks, right? And we should broaden our definition of what data is to because I think the what we get from qualitative qualitative data and what we get from people's stories really should, in many ways, qualify as data. But I think beyond that, it's really important and almost imperative to make sure that we are figuring out what type of information policymakers need, right? It is not the case that all data is useful to them. But if and when you craft the data that can be gathered to be most impactful for or work with policymakers to identify the data sources and the information that can be most impactful for them, I do think it moves the needle. So I think just as we think about partnerships with communities, we also need to think about partnerships with policymakers to make sure that our data is kind of maximally relevant.
As someone who worked for a couple of years on Capitol Hill, I cannot agree enough with this. Both your point, Ali, about the need for stories combined with numbers, and the need to make it relevant. I mean, from my experience, and this was 15 years ago, data has never been the thing that's driven policy ever. And I think it's even more the case now, but I think that's been the case for a long time. And I think, in general, policymakers use the data that's useful for them to advance the ideas that they want to advance. And their ideas are shaped by a whole number of things. And so if you can give useful data to a policymaker that helps to advance something that you've shown has benefit, then that's going to be super useful to that policymaker. The policymaker who doesn't want to move in that direction is not, they're just going to ignore that. But I do think that through, we live in a completely different information ecosystem now with social media. And I think it was Chima earlier who was talking about social media, or maybe Ali, you asked the question, do we need to have, and I'm not a good example of this, but we need to be on TikTok. We need to be on TikTok. We need to be partnering with people who are good communicators on TikTok. And on other social media platforms, because that's that's what the president pays attention to. That and Fox News, So if we want to influence this administration, if we want to communicate what we have shown works and benefits people, we have to find different ways of communicating it.
And I would say, I think this is a both and, right? Like, absolutely. I've certainly, as a data person, I've been in the room with policymakers, and I just know I see their eyes glazing over, and I'm like, oh God, I lost them, right? But who does pay attention to data? Industry people, right? And who can influence politicians that need a narrative? Industry people, right? Like, if I can't influence a policymaker with my data, then I go to the people running an accountable care organization, right? Whose houses could be mortgaged, right? Based on their fiscal performance. The CEOs, CFOs, CIOs of health plans, right? The people who run hospital systems. They still pay attention to data. You better believe it. And they'll build those narratives to get policy changed if it's in their interest. And it's our job, I think, to make them understand that equity is in their interest. No matter what word we use, it's in their interest too.
I think that's such a good point about power mapping, identifying who holds the power to give you what you want, and who, if you can't identify or reach the person who holds that power, who can you influence in their sphere, just like you were saying, Dr. Stockwell. And so, and then also all of you saying, like, we need to work with different people, community members whose voices are really powerful and know what evidence and lived experience is so important. Experiential data, I guess, is what you would say. And then also working with different types of people who know the work best, not just in academia or research, but working together. And so we have a few more minutes. So I want each of our amazing panelists to really share some final reflections, last parting words you want people to know, because we know that no one has all the answers, but you all have amazing wisdom to share. So I'm going to start with Dr. Santos. What's one thing you want to leave us with, whether a lesson you're holding on to, a question you're still wrestling with, or a piece of advice for the rest of us navigating through this moment?
Yeah, sure. Well, first of all, thank you so much for hosting this conversation. I think we need to be having more of these because, like we don't have all the answers. We have to figure it out together. I would say, I'm really curious to think through different funding models for more collaborative research. This came up in the chat as well, but I absolutely it's criminal to me that people are still writing budgets and assuming that community members will volunteer for research. First of all, I can't believe that still exists. If that still exists, we're not doing our job. So baseline standards about what is equitable in terms of the research we do in our processes, right? And then also, how can we really counter the kind of individualistic competition way within academia? And I love the for action portfolios, like the concept of them, because that is what research is for in my mind. It's for social change. And so how do we just build off that in this moment and work together to create better collaborative research systems? And then lastly, I think the idea that polarization is real, but it is also a simplified understanding of our moment. And I think our job as researchers is to get into those nuances and figure out how to counter polarization and bring people closer together rather than farther apart.
Mm, thank you. Professor Ndumele, please, I'd love to hear your closing thoughts.
Yeah, I think what I spend a lot of time thinking about these days is how to balance urgency and grace. The reality is that this is a moment that's unprecedented in which we need to be moving and acting and protecting people. But it's also the case that we should acknowledge that we're not going to always get it right on the first time. Right. So we're going to have to figure out how to create kind of learning communities and to move forward both boldly but with humility to make sure that we are not just improving the system in this moment and responding to this crisis, but also creating the system that we want long term.
Thank you. Thank you. Professor Stockwell, please, final thoughts. For now, final.
Yeah. I would just ask that everyone on this call thinks really hard about what they're willing to do, right, to change the outcomes for people that have been lost by the system. Um, I feel like during this call, I hope you don't think I'm like the industry stooge, here to, maximize profits for stakeholders or whatever. It's not that. It breaks my heart. It breaks my heart that I have to frame health equity um, as a business productivity goal, right? I do that because I've seen it work before, and I've seen it increase the outcomes of the populations I care about. Um, so I just ask everyone to do that, right? Think really hard about how flexible you want to be to work within the systems that we have now versus standing up against those systems. Again, it's not an either or, um, but it's on us to do what it takes, and everyone has their own limit.
Thank you. And Dr. Fichtenberg, please, your final thoughts and reflections.
Yeah. I would say that a few things. One, I mean, I was very down earlier this year. It felt like the work that I was doing was under a barrage of attacks, and I didn't know how to out of it. And I'm one of the lucky few, I'm not being dragged off the street or out of my home by federal agents. But I want folks to remember there are many of us who are really committed to continuing to push for better outcomes for all, including people who have been left behind. And I think the tide is turning, and I'm hopeful now, and I want everybody to hold on to that hope. Look at all of us on this call. We are continuing to do this work to identify ways that we can improve outcomes for all of us. I think we're gonna get there. There are bumps in the road, but we're gonna keep moving in that direction.
Thank you. Thank you to our 4 incredible panelists. I know we all have so many more questions for them. I'm seeing them in the chat, in the question box. I have them. But I think some take homes of this feeling of hope as an action. If the 231 of us in here left were in a room together, I want you to feel that power of being together, of remembering how many folks are in this fight. It can feel really alienating, and so much so in our little computer boxes. But if we were all in person, I think you would feel this so deeply. And so I want you to try to give yourself that feeling. More conversations to come. Please engage with each other and the panelists, and we will be in touch. You'll get the recording, the resources, the links, and thank you so, so much. As you can see on your screen, some final words. Please also at the end take a minute to fill out the survey. It really helps us figure out how to evolve these conversations to best meet your needs. And with that, please go touch grass, everyone. Or if you're allergic, stay inside.